Welcome, guys, and today we will be talking about how to approach a child with pneumonia. Let's start off with the case. We have AB, who's a 27-month-old girl, presenting to you with fever and cough. Now, let's have a look at this child's history. So, she's a previously healthy girl who has 2 weeks' history of fever and worsening cough. Her illness started off with some fever and poor oral intake. The parents didn't measure the fever, but it was tactile and felt to be responding to Adol every 4 to 6 hours. 2 days into the illness of fever, she started having a dry cough associated with some post-tussive vomiting. She was taken to a private hospital where she was diagnosed with pneumonia, and she received IV antibiotics for 3 days along with IV steroids. Now, here we will not be commenting on the management of the private hospital, but we're just having a look at the course of the child's illness. And she was discharged home on oral antibiotics as well as some nebulizations. However, she presented to you because her condition didn't really respond to those medications. She had rapid noisy breathing along with fever and reduced appetite. So, from the way that these symptoms have progressed, and by looking at the treatment that the child has already received for her pneumonia, which was so said to be diagnosed in another hospital, we can see that she doesn't really look like a case of simple pneumonia. She has something slightly more complicated going on. Whenever you have a child with any sort of complaint, as a pediatrician, you should perform a good systemic review because the child is unable to complain about each and every single thing that they have, and the parents may be overlooking a kind of symptom which is not important in their eyes, but if you ask, they can elicit it for you. There's no known recent infectious exposure, the child does not attend nursery, and there's no recent travel or visitor from abroad. So these are also really important questions because it can help you point out the etiology or a possible organism or cause which will help you diagnose the child better. The child has no past medical or surgical history. She is fully immunized, which is also a critical question, and she has no known allergies. And the rest of the history was pretty much unremarkable, including the fact that there's no significant family history and no smokers or pets around the child. So, coming to the physical examination, we can see that the child had a fever of 38.3, and then we look at the rest of the vitals. Now, in pediatrics, it's different from adults because you have a different set of normal values for each age. Now, we said our child was 27 or 26 months old, which means that she's around 2 years old, which makes her a toddler. And if you have a look at the PALS card next to the screen, you will notice that all of the child's, like the heart rate and the respiratory rate, are far above the normal value, which means that she's tachycardic tachypnic, and the saturation is below the acceptable limit of 94 or 95% on room air. So the child was irritable, and after some time they rechecked, it was 94 on room air with some recessions. She's having some aphthous ulcers on the lower side of the lip and the tongue, but the rest of the ENT was clear. Coming to the main part of the examination, which is the chest, they found that there is reduced air entry on the right side with bronchial breathing over the entire right lung field, and there were no other added sounds appreciated. Now, from this simple point in the examination of the chest, we can figure out that there is something on the right side of the chest which is impairing the normal airflow in that side of the lungs. Hence the bronchial breathing, and abdomen is soft with no appreciable organomegaly. All right, let's come to the investigations now. From the investigations, we can see that the child has leukocytosis, which means that she has a high white cell count, and the platelet count is also 693, which is elevated. So Platelets can be elevated in an acute infection because they are a sign of they are an acute reactive agent. So, like for example, the CRP, the platelets can also be elevated, and we can see that the white cell count is mainly neutrophils, which points usually to a bacterial infection. We can see that the CRP and the procalcitonin are elevated, and we can see that the child is having a low bicarbonate, which means that she is dehydrated, but the urea is within normal, so there's no sign of acute kidney injury because of the dehydration. In the blood gas, we can see that the child is having normal pH, but the PCO2 is slightly low, which is going with the fact that she has tachypnea. So she's washing out the carbon dioxide, but the metabolic side or the bicarb is compensating in some form for that. Let's look at the chest x-ray now. So as you can see, it's quite a bad x-ray. You can see that there is a lot of white opacification on the right side of the chest, which is the same place where we heard the bronchial breathing and the reduced air entry. If you look at the trachea, you will feel that it is getting pushed towards the left side. And you can also see that on the right side, as compared to the left side, the costophrenic angle. So costophrenic means the angle between the ribs and the diaphragm. If you look at the left side, it's very sharp and clean, and compare it to the right side, it's definitely obscured, or there is some kind of fluid or some, let's not jump to the fact that it's a fluid, but there is something there which is causing some obliteration of that angle. And we can't really see the heart silhouette well because of this huge consolidation here. And there's an irregular kind of uh, gas pattern on this right side of the chest. So how did you manage the child initially? We started off the child on some antibiotics, IV fluids, and the rest is conservative management, like giving her paracetamol for the fever, collecting some labs, and following up the investigations like blood culture and mycoplasma serology, which the importance of which we will discuss later on in the presentation. So how did the child progress with this management? Unfortunately, she didn't really get better. The respiratory distress and fever continued, and actually she started to need oxygen. She was uncomfortable, she was irritable, she was in pain, she wasn't eating well. And so far, the viral panel, which is basically a swab that we take from the child's nose, which has a big bunch of viruses, it can identify which one it is via PCR. That was negative, including the mycoplasma and the blood cultures. So, a point I'd just like to mention is that for any child who has a very severe pneumonia, we are collecting blood cultures, even though it doesn't look like, the child is having a blood infection per se from the fact that you have found a pneumonia on the x-ray, but it's a kind of screening to check and to make sure that the child doesn't have dissemination of that bacteria from the chest into the blood and vice versa. So because of the initial chest x-ray features that we discussed earlier, showing that there's a weird kind of gas pattern and there's pleural effusion because of the obliteration of the costophrenic angle, we proceeded for a CT scan of the chest so that we can get a better picture of what's going on. So here is the CT scan of this child, and it's very interesting to see this kind of clear picture in this case. You can see the red arrow is pointing towards the lung, which is clearly being compressed by something, which is the yellow arrow, and that is the pleural effusion, which is getting collected over there on the right side. And the green arrow is pointing towards air. So air is not supposed to be present like that in the thoracic cavity. As we know, air is, being is contained within the alveoli and the airways, not outside the lung in the thorax. So these are quite interesting pictures. Take a moment to have a look at them, and then let's see what exactly is going on. So the radiologist helped us out. He told us that there is a right-sided empyema. You can see that the fluid is dark grayish in color on the CT scan, which means that it has an increased density. And given the fact that it's a bad pneumonia, it is an empyema. Um, why is there air in the thoracic cavity? Most probably because there is a bronchopleural fistula. So when you have a very severe pneumonia, if you try to remember the lung anatomy, you have parenchyma and you have airways. So pneumonia is a disease of the lung parenchyma. So if you have a very bad infection that's breaking down the lung tissue and causing inflammation and swelling of that area, it can erode into an airway of the lung, thereby creating a kind of connection, abnormal connection between the parenchyma and the airway or the bronchiole, the bronchi, and this will cause leaking of the air out of the normal airway passage and into the thorax. And of course, the right lung volume is markedly compressed, as we said, because of the air and the pleural effusion. So this all explains why the child is not responding to antibiotic, because antibiotics cannot penetrate into and cause the such a big pleural effusion to dissolve. You need another kind of management to take out this abnormal fluid, infected fluid, and then the antibiotics will start to work. And this is the intervention that we need, and which is what we did. We inserted a chest tube which drained thick, purulent, bloody empyema. There is another intervention which I won't really talk about in details, but just for sake of going over it, fibrinolysis is when you insert a chest tube, you inject a sort of medicine which breaks down the fibers which are present in the infected fluid. Because sometimes if you have an infection or infected fluid, it forms locules or thick fibers, which makes the infected fluid get separated into compartments. So if you can imagine that you have the chest drain here, your drain is open to only a single part or like one locule of that infection, but the rest of them are not being broken down or not being accessed by this chest tube. So in that case, and usually these are found on the CT scan or suggested on the ultrasound, and in that case, we would inject a fibrinolytic, which will basically break down the locules and allow the infected fluid to drain out. But for our patient, because she had the bronchopleural fistula, as you can imagine, you don't want to inject anything that will cause further breakdown in that area or increase her chance of having a full-blown pneumothorax. So that's why we did not perform that in this patient, although her pleural effusion was quite big. And of course, whenever you're collecting a sample from an infected site, you will definitely send it for analysis. And let's have a look at what that pleural fluid was showing us. So you can see the total nucleated count is extremely high with mainly neutrophils. We can see that the cholesterol level is high, which is suggestive of transudate. LDH level is super high, glucose level is within normal, and the protein level is also very high. So all of these markers are classic for an exudate kind of effusion, which is going most with empyema. And finally, the culture eventually also did grow Staph aureus, which was the culprit behind all of these issues in the child. So the final confirmation of whether a fluid is empyema or something else is is ultimately depending upon the analysis of whether it is a transudate or an exudate. Just by looking at the CT scan, you can't really tell what the fluid is, but you can infer what it is based on the other features. So if you have a huge pneumonia and you have a pleural effusion, you will 90% assume that it is an empyema. And once you get a sample, you get the 100% answer. So after we had inserted the chest tube and adjusted the antibiotics based on the culture of Staph aureus, the child really did improve significantly. We started some chest physiotherapy after the initial recovery from the pneumonia to help out with the expulsion of the sputum, and this helped the child a lot. And she improved. We removed the chest tube, discharged her home on antibiotics, and here you can have a look at how her X-ray improved significantly. And of course, we're not doing X-rays very close to each other during the recovery from pneumonia because it's useless. You're not really expecting that as the child is clinically recovering, the X-ray will be improving at that same pace. So we did a follow-up after 2 weeks and it's looking much better. So usually you can do it after like 6 to 8 weeks. So let's come to the actual presentation of regarding pneumonia. We discussed the definition of pneumonia. It is any kind of inflammatory condition involving the lungs, which includes the pleura, connective tissue, airways, and alveoli. And it comes within the category of a lower respiratory tract infection. And which the other diseases in this category are like bronchitis, bronchiolitis, and pneumonia. So the incidence of pneumonia, like in most of other infections, are higher in developing countries for so many factors like lack of vaccination, lack of sanitation, crowding. There is usually a peak in the winter months, but in tropical regions there is no really common pattern, and they can occur in the wet or the dry seasons. What are the risk factors for pneumonia? It's like we discussed, low socioeconomic status, children, school-age children in the household. It's a very common scenario that you have one child who's going to nursery or school and the other is a baby at home. The older child will bring infections to the younger one. If you have a child with certain comorbidities, like we will discuss later on in the next slide, you will find that they are having a higher risk of getting a severe kind of infection. Parents who are smoking cigarettes, especially, this will increase the risk factor, and of course, alcohol use again will increase susceptibility to infections, neglect, and the most critical one is lack of vaccination, which has to be made sure of in every patient that you encounter. So, what are the comorbidities that we are talking about? There is a big list of comorbidities, which, as you enter clinical practice, you will see more and more often, and it will become very easy for you to remember that these kids are the high risk ones. Anyone who has a congenital heart disease, especially if it is an unrepaired or cyanotic kind of congenital heart disease, any condition which will increase the blood flow to the lungs will increase the chance of an infection. Babies with bronchopulmonary dysplasia, because that is a condition which affects the lungs itself. So you can imagine if you have damaged lungs or sensitive lungs and you have an infection on top of that, the body's response will not be that great. You have cystic fibrosis, asthma coming in the same kind of explanation as bronchopulmonary dysplasia, neuromuscular disorders, gastroesophageal reflux, and immunodeficiency disorders. So each of these has its own sort of explanation as to why the child will have a severe kind of pneumonia. I'll go over it very quickly for sake of time. Like if you have a child with a neuromuscular disorder, they have an impaired coordination of swallowing. They have impaired cough a lot of the times because of their weak muscles. So they can have an increased chance of aspiration or choking and thereby getting a pneumonia. If you have a child with tracheoesophageal fistula, that's pretty much self-explanatory. You will have a connection between the airway and the food pipe. So of course the food can end up going towards the lungs and causing a pneumonia. And then you have congenital and acquired immunodeficiency, which is pretty obvious. If you have a bad immune system, you will definitely have higher chance of infection. Why was I emphasizing on the vaccination so much? Because after immunization, the incidence of a Haemophilus influenza infection has really gone down, or you will very rarely see it. But if you have a child who's not immunized, you should keep Haemophilus influenza in your mind as a possible cause. Um, Pneumococcal vaccination also has reduced the risk of a lot of infections. So it's critical that you have the indication of whether your child is vaccinated or not. So what is the pathogenesis of pneumonia? You have impaired host defenses for any reason. You have invasion by a virulent organism, and the inoculum or the dose of the virus or the bacteria which is there has to be of a significant amount in order to create this kind of infection. So the lower respiratory tract or airways, they fill with white cells, fluid, cell debris. This will reduce the lung compliance, increase the resistance, and cause smaller airway obstruction. And this will cause collapse of the distal airways, air trapping, and altered ventilation perfusion relationship. So ultimately, this is what's going on in pneumonia. You have an infection, it causes a reaction, inflammatory reaction within the airways, fluid enters the picture, and you have collapse of the distal airways, and the lung is not able to perform its job, which is ventilation of the air, and subsequently giving oxygen or perfusion to the rest of the body. What are the types of pneumonia? We have bacterial, viral, and rarely parasitic as well. In my presentation, we'll stick to the common ones in like bacterial and viral. So a lobar pneumonia means that one lobe of the lung is affected. Bronchopneumonia is mainly, in the hilar area. It doesn't exactly follow the perfect lobar pattern like a lobar pneumonia does. Necrotizing means that there is breakdown of the tissue and gas production, which is very common in Staph aureus and anaerobic infection. So what our patient had earlier on was a necrotizing pneumonia. Then you have caseating granuloma. As we know, tuberculosis prefers the upper part of the lungs, and we have interstitial or peribronchial with secondary parenchymal infiltration. So interstitial and bronchopneumonia are kind of similar, and sometimes you start off with a viral and you get a secondary bacterial infection. All right. So how do we classify pneumonia? Now this is critical for exam purposes and also clinically. There are four types of pneumonias. You have community acquired pneumonia, which is basically a child who's living in the normal community. It's a normal child, and they come to the hospital with a pneumonia. This is called community acquired pneumonia, like our patient. Then we have hospital acquired pneumonia. So if any child is admitted to the hospital for a non-infectious reason, you have, and he's been there for 48 hours. After those 48 hours, if the child develops a pneumonia, you will suspect that it's a hospital acquired pneumonia. The third type is aspiration pneumonia, which is like we discussed, for example, in those with gastroesophageal reflux or a neuromuscular disorder, when they choke on their gastric contents. This is called aspiration pneumonia. And then we have a very important subset of pneumonia, which is pneumonia in special populations, which are the immunocompromised, children with cystic fibrosis, which is absolutely critical, and with sickle cell anemia as well. So let's start off with the easiest one, which is community acquired pneumonia. Your mentors or your professors will always ask you what is the most common cause of pneumonia. You will probably jump to strep pneumonia, but they want to hear the real answer, which is viruses. So viral pneumonia is far more common than a bacterial pneumonia. And among the viruses, number one is RSV, respiratory syncytial virus. Then you have influenza A and B, and then all the rest of the viruses like human metapneumovirus, adenovirus, which is usually associated with more severe kind of infection, and so on and so forth. When it comes to the bacteria, yes, strep pneumonia is the most common etiology in all ages. Then you have Staph aureus, mycoplasma, chlamydia. When it comes to hospital-acquired pneumonia, Staph aureus is very common and gram-negative bacilli are also common. And unfortunately, nowadays within the Staph aureus, you will have a high chance of having an MRSA as well. What about pneumonia in the special populations? This kind of you need to absorb into your mind, because once you are dealing with an immunocompromised child, and I will keep all of these kind of within the same umbrella, like immunocompromised CF, sickle cell anemia, you need to know exactly what you are suspecting, because your antibiotics will uh, be given according to your suspicion. So the most common organisms are mentioned here. So do keep those in your mind, especially for cystic fibrosis. You have Staph aureus, Pseudomonas, Haemophilus influenza, Burkholderia capacia, Strenotrophomonas multifida. So these are really important to keep in mind, even for the exam point of view. We mentioned about the hospital-acquired pneumonia, and in the aspiration pneumonia, you will see that the causative organisms are a bit different, because these are actually the kind of flora which you find in the gastric